that fatty liver should be considered a functional gut disorder. So these are my disclosures. And I think for the people who are less involved in the hepatology world, these are some of the biggest changes that has happened in fatty liver in the last 2 or 3 years. The name of the disease has changed. So I think many of us may remember the old term of NAFLD, non-alcoholic fatty liver disease, and this has been now renamed as metabolic dysfunction associated steatotic liver disease. So you can see here that now there's this umbrella term for steatotic liver disease, which actually includes all diseases with fat in the liver. And now it's broken down into MESO-D, which has replaced the old terminology of NAFLD. And MESO-D requires steatosis of fat, minimal alcohol consumption, and at least one of these cardiometabolic criteria. So patients have to either be overweight, they might have diabetes, high blood pressure, cholesterol problems, or low HDL. And then on the other end of the spectrum is alcohol-associated liver disease. So I think that we are all familiar with. But I think what is actually interesting and new is that of this new category called MAT-ALD, where in the real world, I think many people and many of us clinicians realize that we've got patients with fatty liver disease, but they don't drink excessive amounts of alcohol, but they have kind of moderate alcohol intake. And so now there's this new category called MAT-ALD. And I think what's useful to know is that people with MAT-ALD in general have a higher risk of liver decompensation, liver cancer than actually MESO-D. So there's this push now that in patients with any form of steatotic liver disease and fibrosis to actually ask them to avoid alcohol completely. So I think before we blame MESO-D or alcohol, I think it's always important in any of our patients with fat in the liver to kind of think of alternatives that can actually cause fat in the liver. So for example, is the patient on drugs like methotrexate, steroids, tamoxifen? These are very common drugs. Or are they on, do they have things like hepatitis C and Wilson's disease? So it's not saying that we do need to exclude every single cause, but it's good to take a good history, physical examination, and look at the drug list. So why do we actually care about fatty liver disease? Well, the answer is right here on this slide, and this was a study we published last year. So you can see that over here in yellow is actually the global statistics for death rates related to fatty liver disease in the world. And here, Southeast Asia, we are world leaders. We are leading the world in terms of deaths from fatty liver disease. So this is a major problem, and I think what is shocking is that it's actually affecting our part of the world even more than other places such as, for example, the US. And this is prevalence of MESO-D by region. You can see right here in Southeast Asia that 1/3 of every patient that we see has some form of fatty liver disease. But actually, these are data that are aggregated over 20 years. And if you dive deeper and actually you only look at studies from 2015 and beyond, so that means in the last 10 years, actually the prevalence of fatty liver disease is actually approaching 40%. In Singapore, where I come from, it's about 40%. Not sure about Vietnam, but I think many of the other Southeast Asian countries, the prevalence of fatty liver disease is really rising rapidly. And what causes fatty liver disease? Well, from a very simplistic point of view, it's actually when there's too much energy in the form of carbohydrates or fat that actually exceeds the liver's capacity for oxidation and export, right? So basically, too much in and too little out. So this is how fatty liver disease progresses. And on this slide, it might look simplistic, right? So a healthy, then steatosis, inflammation, cirrhosis, and cancer. But what is not actually accurately captured here in this cartoon that we drew last year is that actually it's a fairly dynamic disease. So people with, for example, healthy people can get fat and then in the liver, but if they exercise, lose a bit of weight, they actually go back to healthy. Some people with fat, they go on to MASH, but actually it might actually reverse. So it's a very dynamic disease. It can go both ways. And actually it really depends on what time point you're capturing the patient. But I think something that's unique about fatty liver disease is that in most liver diseases, you can see people progress along a continuum of healthy, and then they get cirrhosis, and then they get liver cancer. But in people with fatty liver disease, some of them get a bit of inflammation and a bit of fibrosis, and then they leapfrog cirrhosis and they jump straight to cancer even before cirrhosis develops. So this is a major problem in the liver world because, as many of you know, we only do liver cancer surveillance for those with stage 4 fibrosis or cirrhosis. But then we are now seeing a lot of MASH HCC develop in people without cirrhosis. So these people are not getting surveillance and not getting screened. So it's a major headache for us. So then the next question is that many of my colleagues and friends ask me is, hey Daniel, why don't you just then survey everybody with fatty liver disease? And I think the answer is here on this slide. So this was a study from the Mayo Clinic, and you can see that fatty liver disease is super slowly progressing. So we've got a large, gigantic pool of people with fatty liver disease, and it takes about 15 years, and only 3% of them actually progress to compensated cirrhosis. And therefore, it's not feasible to actually survey everybody with fatty liver disease simply because the disease progresses so slowly. But the nasty part of fatty liver disease is once the patient starts to decompensate, so the moment a patient with MASH cirrhosis starts getting ascites or jaundice and cephalopathy, then they have about 2 years left, right? Before either they die or they get they need a liver transplant. So this was a study that we worked on a few years ago that shows the natural history of decompensation after the first decompensation. So I think in the whole lecture, this is probably the most important slide for people who are general GIs. And it actually shows how one might approach anybody with fatty liver disease or diabetes or obesity. And this is based on, I think, many society guidelines. Essentially, if one has a patient with diabetes, obesity, steatosis, or even a family history of cirrhosis from fatty liver, then the first step actually is to do a fibrosis score. So FIB-4 is simple. It's something that you just need an AST, ALT, platelets, and age. You just go on to MedCalc and you can key in these values. And based on the FIB-4, then you stratify the patients into different risk categories. So if your patient with diabetes has a FIB-4 of say 1, then you don't have to worry. Maybe you just repeat the FIB-4 in maybe 2 to 3 years time. But if your patient with diabetes, or maybe if your patient with a BMI of 28, you do the FIB-4 and it turns out to be 3, then you know that you need to either refer to a hepatologist, or you can actually do a fibroscan, right? To do some risk stratification to see if the patient has advanced fibrosis, right? Because really in fatty liver disease, it's the presence of fibrosis and liver hardening that kills, and not actually the fat itself. So now I think in the liver world, we are kind of moving away from biopsy. We are doing more and more non-invasive tests, and I'll go through these different buckets. So basically non-invasive tests, the aims are number 1, to identify advanced fibrosis, number 2, to actually identify those that might be candidates for treatment for NASH, and number 3, which is now emerging, is to see whether these non-invasive tests can identify resolution of MASH, even without liver biopsy. I'll just jump through these slides. So I think one point that might be worth highlighting is that in people with family, first-degree family members with advanced MASH fibrosis or cirrhosis, the risk of fatty liver in that individual is actually higher, right? So because we now know that fatty liver up to 30-40% is heritable. So if, for example, you have someone who comes in your clinic, you know that their brother or your sister has MASH cirrhosis, then you really want to be very careful about that individual. And this is just one of the studies that we did that showed that if you use family history, you just compute some simple scores, so family history 2 points, diabetes, age 1 point, obesity 2 points, and if it's 4 and above, then actually these guys might be at higher risk for advanced fibrosis, and you might want to do things like a fibroscan or more tests to check out the liver. So this was comparing our family risk score versus fibrosis score, and it actually outperformed FIB-4. So after we do FIB-4, I think there are many various tests that can be done to assess fibrosis. In Europe, I think the ELF blood test is very helpful. In Australia, they developed a test called the ADAPT, which is currently not available in most countries. But suffice to say, I think there are many ways to assess for advanced fibrosis. I think some of the Asian countries, transient elastography or fibroscan might be more available. And here is a study that actually showed that in people with advanced fibrosis, actually transient elastography or fibroscan is actually sufficiently accurate to diagnose fibrosis. You don't actually need a biopsy, and in this particular meta-analysis, you can see that the accuracy exceeds 80%, right? Just skip through this part. Yeah, so I think a lot of times my colleagues ask, oh, then should I do a liver biopsy for my patient with fatty liver disease? In the past, I've said yes, but now increasingly more and more, I'm saying actually we don't need to. So this on the left was a study that we did about 2 or 3 years ago now, where we actually had people with fatty liver disease. We did liver biopsy at 2 time points, so we biopsied them once, at baseline, and then an average of 2 to 3 years later, we biopsied them again. And you can see that among those people with diabetes, then there was a higher fibrosis progression rate. So the fibrosis stage among people with diabetes actually increased faster than those without diabetes. But then we asked ourselves, do we really need biopsy to show that? So then we replicated that whole study, but instead of using biopsy, we actually just used FibroScan at 2 time points. And here you can see that actually the FibroScan data actually tracks the biopsy data very closely. And with using FibroScan, we could also show a greater stiffness progression rate among those with diabetes. So to track disease progression, actually now we in 2025, we don't need a repeat liver biopsy. Just repeating FibroScan will be helpful enough. And you can see that this graph right here is liver biopsy. But you can see that actually if you do things like FibroScan, fibrosis 4 index, they actually can prognosticate survival in fatty liver disease as good as the liver biopsy. So we're moving away from liver biopsy. So I think the next big question that I actually look at for my patients with fatty liver disease is liver stiffness. So why do we actually care about liver stiffness on the FibroScan? And the answer is right here. This is taken from JHAP and the Bavino 7 group. So they very nicely showed in this cartoon that if your liver stiffness on the FibroScan exceeds 25 kilopascals, then there's a higher risk of liver-related death. If the liver stiffness is less than 10, then actually the risk of liver-related death is pretty low. And in between, you can use platelets to help to risk stratify. And the Europeans actually advocate that based on this FibroScan thresholds, you can even decide whether you should or should not scope the patient to check for varices. So what's the magic number to look at on FibroScan? So this was a study we did a couple of years ago, and in this prospective study, we actually found that if your patient with fatty liver has a FibroScan value of more than 30 kilopascals, then that's like a major red flag, right? Because these patients are at like 10 times higher risk for developing liver decompensation. So personally, in my clinic, if the liver stiffness is more than 30 kilopascals, I get very worried. I monitor the patient more carefully. I might even send them to a transplant center because I think that they might decompensate really fast. These are some data on MR elastography, which actually showed that if you do an MRI with an elastography function, then you can actually risk stratify the patients very, very accurately. So this was an interesting study that we did a couple of years back, and I think in this study, the main point is that not everybody with fatty liver and liver hardening behaves the same way. So in this particular study, these patients were MEFIT positive, so meaning the MRI elastography was positive, their fibrosis 4 index were high. So these guys had some fibrosis, but very interestingly, among the patients with some form of liver fibrosis, it's actually those that have normal liver fat, they have lost their liver fat, that actually are the highest risk of liver decompensation. So if you see, so I think some of you might have seen in your clinics that if you see patients with advanced fibrosis, maybe they used to be obese, but now they are a bit sarcopenic, and then you find that their FibroScan shows no more fat in the liver. These are the patients that are the highest risk of decompensation because they have probably progressed to the phase of burnt out NASH. So these patients really need to be monitored very carefully. Just quickly, we go through some treatment response. So in the past, we used to have to biopsy patients twice to assess if the treatment for their MASH was working. But now there's quite a lot of emerging data to suggest that if you use non-invasive tests, this can actually assess treatment response. So for example, if you MRI the patient twice, before and after treatment, if the amount of fat in the liver drops by 30%, then that is associated with MASH resolution. If you do their ALT, so you do LFT before and after treatment, and if the ALT drops by 17, that is also a sign that the patient is responding to the MASH treatment. And if you combine these two, so if the patient has both a drop in ALT by 17 and the amount of fat in the liver drops by 30%, then these patients have the highest association with MASH resolution. This was some index that we created where we did MRI, LFTs before and after MASH treatment, either by exercise or by drug trials. And we showed that if PDFF, AST, ALT drop and we form a score, we can actually very accurately predict MASH resolution. I think we need to validate this in other cohorts, but I think it's an initial step in the right direction. And in this particular study, we compared that MASH resolution index against FibroScan, And I mean, well, the MRI score performs better, but in many parts of the world, there's not much access to MRI. So if you do fibroscan before and after treatment, it can also help to give some idea of whether the patient is responding to the NASH treatment or not. Okay, so what do we recommend for all our patients with MASH? So typically we tell them to eat less food, so try to reduce the amount of calories by 30%. We ask them to lose weight, which I'll speak about in a while. Exercise is good, but exercise alone may help to reduce fat, but we don't know if it actually reduces fibrosis. And typically we advise anyone with fatty liver and any form of stiffness in the liver to avoid alcohol. And I think here's the kicker, right? Because we know that, if someone achieves weight loss of more than 10%, then they can actually reduce their fibrosis. But less than 1 in 10 patients can actually lose 10% of their body weight. If they hit 7% body weight, then the amount that can actually achieve that is only 18%. So practically in my clinic, most of my patients cannot lose like 10 kg in 1 year. I tell them to go for more easy and attainable goals. So like for example, I'll say, I'm going to see you in 6 months, and maybe by then we can lose 1 kg or 1.5 kg. And then that gives them something achievable and attainable to reach for. Of course, there will be some that will exceed that, but I think even a bit of weight loss does help. Right? But clearly based on this slide, we know that the amount of people that they're going to lose significant amounts of weight is going to be limited. Therefore, we need therapeutics. So this is a nice trial. This is a very important trial actually by the late Stephen Harrison, who passed away actually pretty soon after this was published last year. But this was the first phase 3 trial that was positive for NASH, and it's resmetirom, and it actually showed NASH resolution in about 30%, fibrosis regression in about 26%. From what I hear, it's not going to come to Asia anytime soon. So maybe this trial is actually more relevant to us right here in Asia. And this trial was positive also. It's a phase 3 trial in MASH, and it's based on semaglutide, GLP-1 agonist, which actually, I think GLPs are now increasingly more available in Asia. In Singapore, I think semaglutide is approved. In Vietnam, I believe liraglutide is being used. Yeah, but these are very encouraging data because in patients with MASH, with either stage 2 or 3 fibrosis, 63% of those who receive semaglutide actually developed resolution of their MASH and their fatty liver, and 36% actually had a reduction in liver fibrosis. Right? So this is very encouraging data, and I think it's going to form the backbone of our treatment for MASH for the next few years. And I think what's also encouraging is there are many other molecules that are undergoing phase 3 trials, and I think the next couple of years for fatty liver is going to be very exciting. So in summary, I think my time is up. MESO-D is the new terminology that is now replacing NAFLD, and MASH is now the new term to replace NASH. Non-invasive tests are now replacing liver biopsy in most of clinical practice. And now many classes of drugs are showing promise in the treatment for MASH. Now the GLPs are approved and available in Asia. So I think this is changing the face of how we treat NASH. So with that, I thank you very much, and thank you for paying attention.